like few minutes first for people to join. Is that okay?
That's perfect. Will we see that they've joined?
Yeah, I'm chasing it here in like the second window. It should be fine.
Okay.
Mhm. Okay. Yeah. Should you wait like 2 more minutes? Is that all right?
I think we should wait till we have some people.
Yeah.
Because now there are no people. Is that correct?
There are 2 that I can see.
Okay.
It's probably 3.
I
Going,
can't see
going
them.
up. Going
Oh,
up.
thanks.
Okay. Going up to 10 already. So should we slowly start? Is that okay? Okay. So I would like to welcome everyone, and especially you, Miss Neal, and thank you so much for like doing this for us. We really appreciate it. And I honestly think the topics we are going to discuss today are really essential for every junior doctor, and we can only like benefit from it. So it's very important that we can talk about it today in like this nice atmosphere of like only us to do this. So it's really nice, and thank you for that. And for all of you who not know Miss Neal, she is our urology consultant, sorry, in Hampshire Trust. So we work together in Royal Hampshire County Hospital in Winchester in the UK. And Miss Neal is also an author and co-author of over 100 publications, and one of the authors of Oxford Handbook of Urology. And she is really keen to teach us, even on the wards. She wouldn't miss any opportunity to teach us junior doctors. So I'm really glad we can do this webinar and and learn from you. During the whole webinar, you can ask questions. You can put them in the comments. They might be in Polish or English. It's all right if you prefer to write them in Polish. We can just translate them. It's okay. If because this is the first webinar we do in English, not in Polish, we prepared a list of useful vocabulary on urology. So urology terms, there is like a pocket vocabulary that we just posted on an event, so you can open it. It's all in alphabetic order, so it's easier to find all the words. But still, if you don't understand anything, just ask questions. You don't have like the opportunity like this very often to have a specialist just like here for you, keen to teach you and to explain you things. So just use it and ask as many questions as you can. And Miss Neal is also like very keen to answer all of them and make this webinar as interactive as we can. Can I also say something in Polish quickly? Is that okay for the audience? Więc cześć wszystkim jeszcze raz. Ja jestem Kasia, jestem koordynatorką projektu Spółdzielnia Wiedzy. Bardzo dziękuję za to, że dołączyliście dzisiaj. Mam nadzieję, że dużo wyniesiecie z tego webinaru Myślę, że będziemy dzisiaj rozmawiać na tematy, które naprawdę są gdzieś tam potrzebne i każdemu się przydadzą w codziennej praktyce lekarskiej. Jeżeli chodzi o pytania, tak jak już mówiłam, nie bójcie się ich zadawać, możecie zadawać je po polsku, możecie zadawać je po angielsku, nie ma tu żadnego problemu, zawsze możemy wszystko przetłumaczyć. Również chciałabym powiedzieć jeszcze, przypomnieć, że webinar jest organizowany przez naszą Spółdzielnię Wiedzy Kobiet w Chirurgii w ramach projektu Spółdzielnia Wiedzy i zachęcam ogromnie do oczywiście obserwowania naszej grupy na Facebooku i śledzenia naszych działań, ponieważ dzisiaj mówię, to pierwszy jest webinar po angielsku, ale jeżeli to gdzieś tam fajnie wyjdzie i wypali, to jak najbardziej będziemy chętne, żeby robić takich więcej. Także dawajcie też nam feedback, dawajcie znać, piszcie komentarze i mam nadzieję, że będzie wszystko super i będzie się Wam podobał dzisiejszy webinar. Okay, Miss Neal, thank you so much, and yeah, over to you.
Great. Thank you very much, Kasia. And thank you for those of you who've taken the time to join on an evening for this webinar. As Kasia has said, I'm very happy for it to be as interactive as you want. But apologies, I only speak English, so I'm very impressed by all your abilities to do this in several languages. It's fantastic. So we're just going to cover 3 kind of common urology emergencies. So we'll start with torsion, then talk a bit about stone disease and colic, and then go on to retention. And there's time at the end if there's questions that come to light at the end, but I'm happy to take them as we go through. So Kasia, feel free to interrupt me. Okay, so torsion is something that is quite common, but that you may not see a lot of in training or sort of junior doctor years, and it's important to know how to manage it. And the reason it's important is that it is one of the true urology emergencies. So we like urology as consultants because we don't often get called out of bed. And even this as consultants, we wouldn't be called out of bed for, but unfortunately the registrar would. So it affects about 1 in 4,000 males, and it has a kind of bimodal distribution in terms of age. So it affects neonates, but that's not necessarily relevant unless you're looking after them. And the other peak that you would be involved in seeing is boys between the ages of 12 and 18. So it's thought possibly that one of the risk factors is related to larger pubertal, post-pubertal size, and it's more common in the left than the right testicle, but clearly it can affect either. And it's the commonest cause of testicular loss in adolescence. So it's important that we prevent testicular loss, and the reasons that we lose testicles through torsion are generally because of a lack of clinical suspicion and delays in management. So the salvage rate depends upon the time since presentation. So if a person presents within 6 hours of pain, generally speaking, most of them will be salvageable. So between 80 and 100%. But as you can see from the graph here, that figure drops off quite rapidly beyond 12 hours. So although it's low and the chances of salvage are low at 24 hours, it can happen that a testicle can be saved. So it doesn't mean that you wouldn't explore, it just means that it's much more likely that the testicle would be lost. So just a little bit about the pathophysiology of torsion. It's thought that most of them at least relate to a Clapper-Bell deformity, which is where there's a high attachment of the tunica vaginalis, which allows the testicular rotation and therefore the torsion on the cord. So the intravaginal twist leads to venous engorgement, which subsequently leads to ischemia and infarction. And it's said that you need a 720-degree torsion to cause ischemia. Whether that's strictly true or not, we don't know, but you certainly need more than 360 degrees. So the history is usually that of sudden onset of unilateral severe pain. And about half of patients report some episodes before then, which is attributable to some degree of intermittent torsion, but they usually resolve. Patients sometimes have abdominal pain and sickness, sometimes vomiting, loss of mobility, but generally speaking, that's all related to the pain itself. And unless they've got an associated epididymitis, or indeed that is their cause of pain, so epididymoitis, they don't usually have LUTs, so urinary tract symptoms, or a fever. And theoretically, again, previously fixed testes can tort. It's extremely unlikely. So if a patient comes along with testicular pain that's had a previous fixation, we should suspect that it could be a torsion. So in terms of surgery, the timing is really important. So essentially, you can't get these patients to theatre soon enough, but you can definitely get them to surgery too late. So if it's needed, I've written RSI here, which stands for rapid sequence induction. So whereas for other procedures, you'd want to wait 6 hours until they're starved, you don't wait for torsion until they're fasted and safe for anaesthetic. So you get them straight into theatre. And then you'd perform a midline raphe incision or a transverse incision. It doesn't really matter which. The aim is to deliver the testicle. So we each have our own preferences. Once you've delivered the testicle, if you're unsure about its viability, so if it looks very, very dusky, so black, then you detort it, so untwist, wrap it in warm saline soap swabs and just wait. And you can wait and look at the other side during that time, because if it happens on one side, it's more likely to happen on the other side. So you must look at the other side for fixing to prevent future torsion. And if you're still unsure when you've waited, then you can incise the tunica albuginea and see if the testicle bleeds. And if it bleeds, that's a good sign it's still viable. So you would then close the tunica and fix. And the fixation should be 3-point, so to prevent further twisting. And you can use, generally it's recommended a non-absorbable suture, so PDS, but it probably doesn't matter because whatever you fix it with, it will cause enough of an inflammatory reaction to not tort again. And as I've said, you should fix the contralateral side because the deformity is likely to be bilateral. So you want to prevent another torsion. So that's it for torsion. Are there any questions about that before we go on to stone disease? I think not. Okay. So in terms of stone disease, it's very common and becoming more common in the UK, and I suspect Poland as well. So there's been a massive increase in the past 10 to 20 years, much more so than any other urological activity, so including cancer. So quite a few years ago, 12 years ago, lithotripsy was performed almost as frequently as surgery for the prostate or for bladder tumours. And stone surgery, so ureteroscopy, was performed more frequently than all the surgeries, radical surgeries for cancer. So it's a massive problem, and there's many reasons why that's happening, and I'll talk about that in a minute. So generally speaking, kidney stones are often asymptomatic, and the natural history of renal stones is sort of up for debate, but it can be said that probably a quarter of stones would need intervention if we look at all stones. And predictors of failure of observation, so if we were to manage stones without any intervention and just monitor them, if they're above 4 millimeters, they're more likely to progress. So that means either they grow in size and cause symptoms like pain or infection, or they move into the ureter. And interestingly, lower pole stones probably grow more than upper and middle pole stones. Lower pole stones themselves are generally more amenable to just being monitored because they're less likely to spontaneously move on the whole. And if we look at other factors that are associated with stone growth, then urine and serum uric acid levels correlate with that. And that's important in terms of why stone disease is increasing, because the biggest factor is really related to a Western diet. So high fat, high salt, and general immobility. So metabolic syndrome, those patients who have that classic picture of metabolic syndrome, so a degree of insulin resistance and obesity, are much more likely to get kidney stones, and they get uric acid stones because they're relatively hyperuric. So they've got high levels of uric acid in their urine, which means that they're more likely to get uric acid stones. So how do we investigate patients that come along with colic? There's the basic investigations that we need to do. So urine dip, which is important to look for infection, but also to confirm blood is present. Now, they don't always have to have blood in their dip if they've got a ureteric stone, but most of them would have. Blood tests are important to look for renal function, so UNEs, and to check for raised inflammatory markers, so white blood cells, CRP, and also to check for calcium level. And uric acid isn't particularly important in the acute setting, but might be useful later. Further bloods really depend on what you're going to do with your patient. So things like a clotting profile, if you're thinking about surgery, particularly a nephrostomy, that might be important. And we'll talk about imaging later, but clearly we need imaging of some sort. But the most important thing to ascertain early on is whether the patient is septic. And if a patient's septic and has got a stone, that's another urological emergency, because an infected, obstructed kidney is life-threatening. So there's lots of forms of imaging, and they've all got some place even in an acute setting. So plain X-ray KUB is important for monitoring purposes. So if you have a stone that's proven on a CT scan, to know whether it's visible on a plain X-ray is really important if you're managing the stone conservatively and you want to know if it's passed in the future. Ultrasound is important if the patient can't have a CT. So for example, if it's a pregnant patient, or if you know already that there's a stone and you're looking for hydronephrosis. So that's a useful modality to look for hydronephrosis. A CT-KUB is our gold standard diagnostic test for ureteric stones, because it gives you lots of information. So it tells you where the stone is, how big it is, whether there's associated hydronephrosis, and whether the patient's got 2 kidneys, and whether or not they've got any other pathology. CT urogram can be helpful if you're suspicious about an underlying cancer, perhaps, as being the cause of the colic. But it's not something that we would do immediately because it's a much higher dose of radiation. So a CT-KUB is about 4 millisieverts and a CT urogram is nearer to 30 millisieverts. So it's a much higher dose. And an MRI is useful, usually reserved for patients who are pregnant. So an MR urogram is helpful to look for a stone. And it's very dependent on having a really good radiologist who can look at the report and look at the scans and tell you on the report whether there is a stone, but it also shows you the presence of hydronephrosis. So lots of tests, but CT-KUB is the gold standard. So we've talked about why a plain film is important, and for monitoring purposes, it's good, but also in terms of treatment. So you can see the CT-KUB here shows a stone in the left proximal ureter. I'm not sure whether I have facilities to arrow anything. I don't think I do. But if you wanted to monitor this stone and not intervene, you could do a follow-up X-ray if it's visible on plain film. And the other reason plain film is important is if you can see the stone on plain film, then one of your treatment options becomes lithotripsy. So shockwave lithotripsy, which uses ultrasound, but relies on fluoroscopy to visualize the stone before treatment. So it's a helpful adjunct. This looks like it could be a contrast CT, but is not a contrast CT. It's a patient who's got quite a high stone burden in their right kidney. And although it's only a single section, they don't have a left kidney, which is another reason why CT is helpful, to show you the presence of 2 kidneys. Clearly, if a patient's got a stone in a solitary kidney, you'd be a little more cautious about your decision making. So if there is obstruction, it's important to know whether the kidney's functioning. And this isn't necessarily a scan you'd get in the acute setting, but is one that's really helpful to look at function, particularly of both kidneys. So this is a DMSA nuclear medicine function scan. And these pictures in the grey are taken from the back of the patient. And you need to just have in your mind whether or not there's uptake of the tracer in the kidney, so whether it's functioning, and also whether there's scarring, so by which you might see sort of missing parts of this uptake. And it's helpful to give you a bit more information. So I touched on briefly the link between X-ray and CT, and you may or may not know the CT comes with what's called a scout image. So that's a sort of plain X-ray part of the CT. And it's helpful to guide whether or not you can see the stone on X-ray. So this is just a bit of information about the utility of it. So the take home really here is that all stones that are visible on scout are also seen on plain X-ray. So if you see a stone on the scout film, you don't need a KUB. But if it's not visible on the scout, then you should do a KUB X-ray alongside the CT for the reasons that we've just explained. So what's the natural history of ureteric stones? So if you're seeing a patient in the emergency department with a ureteric stone, it's helpful to know what would happen if you did nothing more other than hopefully give the patient some analgesia. And whilst we touch on that, the best analgesia for somebody with ureteric colic is NSAIDs. So ideally 100 milligram diclofenac or Voltarol suppository would be the best first line analgesia. So lots of studies have looked at what happens spontaneously with ureteric stones, and about 2/3 overall pass spontaneously. And as makes sense, the higher stone passage rates are those that are more distal. So patients with a small distal ureteric stone can safely be managed conservatively, and patients with a larger proximal ureteric stone are probably best managed with some intervention. So we think, as I've just said, that it's probably safe to manage small ureteric stones conservatively, just with monitoring. But actually, the lack of pain doesn't mean that there's no obstruction. So it's important to monitor them quite closely, and I'll talk about that in a minute. The other thing that has a role is medical expulsive therapy. So that can be with a variety of agents, but the one that's most been studied is tamsulosin, so an alpha blocker. And there's reasonable evidence that for stones that are over 5 millimeters in the distal ureter, then giving tamsulosin reduces the analgesic requirements of patients and probably improves the spontaneous stone passage rates. So given that you're thinking perhaps about treating a mid-ureteric stone conservatively, it's not yet distal, but you hope it would become distal. So the simplest rule is to consider tamsulosin for all patients with stones over 5 millimeters that you're managing conservatively, but being aware that it's not licensed at all for use in women, and it's not licensed for this purpose, but it has been well studied.
Can I ask a question actually right now, as we are on tamsulosin? From your own clinical practice, what do you think about tamsulosin? Do you really see like those like beneficial impact of it for like patients?
I think it has a small use in patients that you're managing conservatively who have had quite a large amount of pain, but you want to give them a conservative approach, then tamsulosin is helpful. Most patients, especially now, they seem to want treatment rather than be managed conservatively. And I don't quite know why that is. There's lots of reasons, perhaps wanting to get back to work, just wanting the stone gone, but there's lots of patients that don't want to be managed conservatively. And clearly, I don't think tamsulosin has a role there, because it really is over a longer period of time that there's a benefit.
And for those patients who we cannot give NSAIDs to because they're, for example, allergic, what would be our second choice of pain relief? That'd be opioids.
Yeah, good question. So opioids can make the pain worse, but for some patients they work well. So paracetamol and codeine are probably the best. Giving tamsulosin to those patients is probably helpful. And there's not really any role for buscopan or antispasmodics. And there's some weak evidence that calcium channel blockers, so nifedipine, might have a role.
Okay. Thank you.
Okay. So in terms of leaving ureteric stones, we worry about this silent obstruction. So we're sending patients away. They might be slightly hydronephrotic, but that's not an absolute indication to intervene. And their renal function might be a bit off. So you'd be a bit worried about just leaving them. But stones above 5 millimeters are more likely to develop obstruction and require intervention. And this just shows you some information about that. So about 20% of patients had a greater than 7% decrease in function. And this is in the acute setting with rhinography. But 16% returned to normal when they were stone-free. And only 3% of kidneys whose function remained impaired had fallen below 25% of overall renal function. So whilst there might be a temporary loss in renal function, it's probably transient. And there's some limited animal studies that suggest probably 6 to 8 weeks of obstruction is reversible, but it's quite dependent on individuals. So I've mentioned when we would want to intervene and the importance of looking for sepsis. So the indications are fever, infected urine, impaired renal function, so grossly impaired renal function, not a sort of mild drop in EGFR, intractable pain despite your NSAIDs and tamsulosin or whatever else you've given them, and failure for the stone to pass after a trial of time. But quite how long that time is, we don't know. So the smaller stones can probably safely be left for a few months, and the larger stones, therefore associated with a higher risk of obstruction, probably need to be removed sooner. So I've mentioned about this length of obstruction being related to renal recovery, and the time at which they're obstructed, as I say, is really unknown, but 4 weeks tends to be the mark at which we start to worry. So we would want to see patients back in clinic within 4 weeks, if not sooner, when we're managing them conservatively. And interestingly, I don't know the stats in Poland, but in the UK, we get more deaths from infected obstructed kidneys than we do from testicular cancer. So it's about 150 a year. And really, if they're coming into hospital early, so not the patients who perhaps have been admitted under the medical team for many, many weeks before we're called, but if we're seeing them early, we need to be decompressing them really early. So this is not necessarily an emergency treatment for when we're talking about kidney stones, but it can be an emergency treatment for ureteric stones. So shockwave lithotripsy, as I've mentioned, is ultrasound treatment delivered with fluoroscopy visualization, as you can see in this picture. You clearly can't have it if you're pregnant or if you've got an uncorrected bleeding disorder, because it causes bleeding. And if you're talking about treating kidney stones, then you can't use it if they've got uncorrected hypertension. And regardless of the position of the stone, and the same for any stone procedure, you shouldn't give treatment if the patient's got an untreated infection. There are other things that are relative contraindications, but it's a good treatment modality for many patients.
I think we have a question.
Okay.
About still the management. So it's can you tell us about antibiotic therapy in patients with renal colic? If you give antibiotics routinely to every patient with a renal colic, or
Absolutely not. So that's a really good question, because it's something that some people in some emergency departments particularly do. And it's a worry because if you're giving antibiotics, you're saying there's an infection that you're treating. And if the patient's got a stone with hydronephrosis, then essentially they must, by definition, have an infected, obstructed system, which needs sorting, not antibiotics and home. So no, we don't routinely give patients with stones antibiotics. If they've got a urine infection and a non-obstructing stone, then they need to be managed really carefully. So yes, antibiotics, and maybe even on an outpatient basis, but with a very early review date planned, like 1 week, and advice about when to come back. So if they have fever or worse pain. And then if they've got an infected, obstructed system and you're planning to decompress them with a nephrostomy or a stent, then you would load them up with intravenous antibiotics. And we give something fairly broad spectrum, so gentamicin and coamoxiclav.
And there is also a comment to say that when I asked you about what would we give if not NSAIDs, there is a comment saying that in Poland we normally give so the metamizole, but I've never seen it used in the UK, or papaverine, but I've never seen used any of those in the UK. Have you heard of them?
Yeah. So we use them for irritable bowel syndrome, and I suspect, although I'm not sure, I think their mechanism of action is like buscopan, but maybe people in your audience know best, rather than nifedipine. I will look it up. That's good learning for me too.
I just wanted to clarify that NSAIDs, the word that we use like plenty of times already, those are just NLPZ in Polish. Sorry, it's just like, those abbreviations that we just don't have. So I just wanted to clarify that. Cool, thank you.
Great. So this is just a little bit of information about lithotripsy, because I don't know whether you've all had the chance to see it or not. There's lots of different machines that rely on an energy source which delivers the shockwave, and that can either be electrohydraulic, piezoelectric, or electromagnetic. And then a focusing system, which is either an acoustic lens or a cylindrical reflector that focuses the waves onto the stone. The imaging system, as I've mentioned, so that's the fluoroscopy that you need to be able to see the stone, and then a coupling mechanism. So generally we put some water under the patient when they lie on the bed to make sure the shockwaves hit the patient. So the way it works, clearly, if a patient has a what we call a large skin to stone distance, you're somewhat limited. So it's a sort of fancy way of saying that the patient's rather fat. But if you've got more than 16 to 19 centimeters between the skin and the stone, then it's unlikely that lithotripsy would work. This is if you're really interested in knowing the outcomes of lithotripsy, which some of you might be, but in terms of the success rates. So again, the more chance of success is with the distal ureteric stones, but it's very user dependent. But it just goes to show that even with proximal ureteric stones of over a centimetre, the success of lithotripsy approaches 70%, whereas with ureteroscopy, so that's the URS, ureteroscopy and laser stone fragmentation, it's about 80%. So it's well worth considering as a first-line treatment followed with surgery if it fails. So we have some fairly strict guidance in the UK from our Urology Association, and also something called Get It Right First Time. I don't know if there's a Polish equivalent, Kasia. But all patients should be offered intervention within 24 hours of a ureteric stone episode. So whether that's lithotripsy or what we call primary ureteroscopy and laser stone fragmentation. The primary just means that we're doing it at their first presentation. There's no role for, I've said presenting, which is ironic given that I'm presenting, no role for pre-stenting. So there's no increased risk, increased chance of success if you have a stent placed before ureteroscopy to facilitate access. So some countries, particularly Germany, would stent all their patients before ureteroscopy. But I think, unfortunately, that probably relates to a financial incentive for doing so. So we don't pre-stent our patients. what does affect stone-free success is the stone itself, which you can't change, unfortunately. So the stone size, the number of stones, and the total stone burden. As part of this, I thought it was helpful to mention stents. So putting a stent in for an obstructing ureteric stone as a treatment is an absolute no-no. So we would only put in a stent if we are trying to drain an infected, obstructed system. And part of the reason for that is that they're miserable things to have. So there's been lots of studies that look at the quality of life with patients with stents, and they're just awful. So over 80% think that it affects their daily activities, and they can get terrible urinary symptoms such that the stent has to be removed before the stone's been treated. And a lot of them have to stop working, or at least limit their work activities because of the stent. So it has huge socioeconomic impact as well. So that's it for stones. Any questions, or shall I go on to retention?
There is one more question.
Okay.
So the question is about pregnant women and how would we manage a pregnant woman. We said that in the diagnostic we would use an ultrasound rather than X-ray or CT. What about the treatment of the stone?
Yeah, that's a good question. So it presents a bit of a diagnostic challenge because hydronephrosis of pregnancy is common, particularly if they have right-sided colic. So right-sided hydronephrosis from a gravid uterus is common. So you do need, before you treat a pregnant woman, an absolute diagnosis. So we would get an MR urogram to confirm the stone. The management is the same but different. So the same as in the same indication. So if they have intractable pain or signs of sepsis or deranged renal failure, and that's another thing to bear in mind. So the creatinine during pregnancy drops. So you might see what appears to be a normal creatinine, but actually it's 50% of what it was last week. So we tend to not want to leave a stent or a nephrostomy in pregnant people because they're at higher risk of encrusting their stent because of the hypercalciuria during pregnancy. You might regret asking this question. Sorry for the detailed answer. So we don't want to leave things in. So essentially, we try and get them stone free. So a senior urologist, so a consultant, would do a primary ureteroscopy, and you can do it under local anaesthetic if necessary. If they're in the second trimester, it's usually the safest period at which to give a GA and remove the stone. So it requires a bit of thought and fairly senior input early on.
Because usually when we put a stent in our hospital, we use an X-ray as well.
Yeah. So we would use X-ray for a primary ureteroscopy during pregnancy, but very limited doses.
Okay.
So that's why it needs to be an experienced person. So you'd maybe take 1 or 2 pictures only.
Thank you. That's actually really interesting, especially with the creatinine level, because I would never thought about it.
Good. So finally, retention, because urologists would not be known for being anything other than catheter experts if some people had their way. So what is retention? It's a painful inability to void with relief of the pain following drainage of the bladder by catheterization. So it's important to know that definition because people might say the patient's in retention for a variety of reasons that aren't actually retention. So there's lots of kind of underlying causes for it related to either bladder outflow obstruction, so that's BOO, a low bladder pressure, so the bladder just simply can't empty, or if there's disturbed sensory or motor innervation, or even a central failure. So the common causes are listed here. The colours, unfortunately, are representing gender because it seemed the simplest way to do it. So BPE stands for benign prostatic enlargement. Prostate cancer, urethral stricture, prostatic abscess. And then there's general causes, so hematuria and clots, which is quite common. Lots of drugs can cause retention of urine, but particularly anticholinergics and sympathomimetics. General anaesthetic drugs, so it's very common after a general anaesthetic for old men to develop retention if maybe they'd had some mild obstructive symptoms before surgery, and then it just tips them over the edge and they can't pee. Sacral nerve compression or damage, so cauda equina syndrome, is very important to exclude as a cause of the retention, which is part of the reason why it's very important to do a rectal examination, to not just assess the prostate, but also to assess anal tone. And rare things like pelvic fractures with urethral injury, it's uncommon that retention would be the presenting symptom, but we should just suspect that patients have a urethral injury when they have a pelvic fracture. It's quite common. And then general neurological things, so multiple sclerosis, diabetes, and then in women, pelvic prolapse or pelvic mass, and Fowler's syndrome, which is an association between a raised urethral sphincter pressure and polycystic ovary disease, amongst other things. So how you manage retention is probably quite straightforward, although it's not always that easy in clinical practice. So the patient needs a catheter, and they need usually a urethral catheter, sometimes a suprapubic catheter. We would tend to choose the smallest catheter possible to do the job, but generally speaking, a 16 French catheter is fine for men and women if they've not got hematuria. If you're worried about clot retention, then the patient should have a 3-way catheter, ideally a 20 or larger, to allow clot washout. It's very important that you document the volume, not least because it guides you as to whether the patients will have a diuresis, but also in terms of predicting their success in having a trial without catheter, which is the TWOC. So the success of their trial without catheter depends whether it's what we call a precipitated retention or a spontaneous retention. So whether or not they've got a reversible cause, so something like constipation, which is a very common cause. And when you treat that, it's very likely, for example, that they would pass their TWOC. We would tend to give all men who present with retention tamsulosin for at least 24 hours before they have a trial without catheter. And if they've got a very large prostate, then you might want to think about adding finasteride, but bearing in mind that that takes at least 3 months to work. So they may need to wait for their trial without catheter. And then either the patient can have a long-term catheter or can learn intermittent self-catheterization. And that depends on the patient's motivation and hand dexterity, amongst other things. And for women, it's exactly the same in terms of having a catheter and documenting the volume. The causes of retention in women tend to clearly be different. And for that reason, most of them can be managed with intermittent self-catheterization. And then in the longer term, if you're suspecting something like Fowler's, then the option of treatment includes sacral neuromodulation to facilitate bladder emptying. But you would still, if the patient didn't have constipation and it was a female patient, you would still consider giving tamsulosin to facilitate their TWOC. So just a little bit about TURP. So TURP stands for transurethral resection of the prostate. And it comes in many different guises, but some form of prostate surgery for retention is a very different entity to the same procedure just for symptoms. So the complication rates are higher and the need for blood transfusion is higher. And unfortunately, although the death rate is very, very low, it is higher amongst patients in whom you're doing it with retention. And that's generally because they've had an indwelling catheter and so have almost all got bacteriuria, and some of them are symptomatic. So treating infection before TURP for retention is really important. And there's just a little bit of information here about predicting who would be unable to void after a TURP. The important thing about this information is that only 1% of patients who have a TURP for retention would fail their TWOC. So even those patients who've had a degree of chronic retention, whose bladder function probably isn't brilliant, will eventually almost all be catheter-free by 12 months after their TURP. But they might just need a few trial without catheters. I just wanted to talk a little bit about post-obstructive diuresis because it's something you'll probably come across when a patient with high pressure chronic retention has been catheterized. So that means that their bladder's been very full for a long time and has caused back pressure on their kidneys. And that leads to renal failure. So they diurese and they lose lots of salt and lots of water. So they're producing really poor quality urine. The other reason it happens is that they lose their corticomedullary concentration gradient. So they're having the same kind of arterial blood flow through the kidney, but their urine flow is reduced. So they lose the concentration gradient. So they're producing lots of dilute urine, and they have an elevated serum urea, which causes an osmotic diuresis. So these can be quite tricky patients to manage, but it's also the nice aspect of urology in that we have some renal physiology to think about. So when you've catheterized them, it's really important to have a very strict fluid balance. So input, output on an hourly basis, and a lying standing blood pressure, and also daily weights. So if the patient probably is going to be staying in a few days, then a daily weight is very helpful to assess their overall fluid status. The serum creatinine is important because it predicts the likelihood, together with the presence of hydronephrosis, of the patient having a post-obstructive diuresis. So a patient might come in with a residual volume of 1.5 litres of urine, but if their creatinine is normal, it's almost virtually unlikely, very unlikely, that they would have a post-obstructive diuresis. Whereas somebody with an 800 ml residual who's got deranged renal function is more likely to have that post-obstructive diuresis. So the kidney function is a really important guide. And it takes quite a while to fully recover after the patient's been decompressed. So when they've had their catheter in, they go through this early tubular phase of recovery, which just takes a few weeks. But then there's a longer glomerular phase, which takes up to 3 months. So that's the reason why once we've put a catheter in, if the patient then wants prostate outflow obstruction surgery, we would wait at least 6 weeks and nearer 3 months so that their kidneys are functioning as well as possible, so that those risks we talked about of surgery are as low as possible. So if you do their surgery too early, their complication rates are much higher. So the other thing to think about, in addition to doing the ultrasound, which you've probably already done, is fluid replacement. So when patients are losing 200 mils of fluid an hour for more than 2 consecutive hours, traditional guidance would be that you'd replace that fluid, which is fine at 50% of the previous hour's output. But if it's daylight hours and the patient is not very old and is able to drink, then maintaining a very good oral intake along with a close fluid balance is more than adequate, because you run the risk of driving the diuresis. So running fluids as fast as they're peeing them out will just mean that the patient stays in hospital for weeks, constantly diuresing. So there is a balance that needs to be found. So if you start fluids, just be careful to keep up with what they're needing. So just a brief summary of the 3 conditions. So torsion is a real emergency, and time is absolutely critical in terms of salvaging the testicle. And remember, if there is a torsion, that you do 3-point fixation of both testicles, not just one. For colic, the most important thing is to exclude or confirm an infected obstructed system and then manage it appropriately. You need pretty thorough but appropriate investigation. So urine dip, bloods, and CT-KUB. Adequate analgesia, we've talked about NSAIDs, and timely follow-up. So if you're managing patients conservatively, they need to be seen soon. With retention, it's important to exclude a sinister cause, particularly cauda equina. Remember how to manage post-obstructive diuresis and follow the patients up appropriately. So whether that's with a TWOC after the alpha blocker, or whether it's deferring their TURP surgery. So I'm happy to take any other questions or general comments about that.
We can wait for a sec to see if there are any questions anymore. I think, yeah, this I'm really happy that you added it, the door should do it. Thank you.
Welcome, Kasia.
But I still haven't seen one yet.
No, and there's a lot of patients that come along with suspected torsion who they don't have very convincing symptoms. Sorry?
We have a lot of them coming to the hospital. Even today we had one, but it's just never a torsion.
And once you've seen a torsion, it's very good to know how uncomfortable the patient looks and clinically how it feels, because it's very different from an infection usually.
So there is a question about renal colic again, and the ultrasound. If you would recommend doing it routinely for a patient without like any complications.
So no.
it might be the guidelines in Poland to do the ultrasound.
Okay.
Do you do them?
No. So the reason that I wouldn't do it is because there's easy access to CTKUB, which gives you a confirmatory diagnosis. So the trouble with ultrasound is that it's a pretty gross test of obstruction. So you will see if there's hydronephrosis. It's very difficult to identify anything other than a distal ureteric stone with an ultrasound. So you may, when you're scanning the bladder, see a loss of ureteric jet, which could suggest that the stone is in the distal ureter or is causing obstruction somewhere. Or you might see the stone in the distal ureter near the bladder, but you wouldn't be able to visualize a mid-ureteric stone. So you might only know that the patient's got obstruction and not know the cause. So you would then need further imaging. So unless CTKB is of limited availability in the hospital or the patient's pregnant, then there's not much role for ultrasound in the acute setting.
Okay. And if we do an X-ray, just as a follow-up, if the patient passed the stone, when should we do it? After how many weeks?
It's a good question. So it's a good idea to do one about 4 weeks if you're managing the stone conservatively and you've been able to see it, because by that point there should be some migration of the stone, at least if it's not passed. So the role of surveillance X-rays is a bit controversial, because if you can't see the stone, it doesn't mean it's absolutely gone, because there can be overlying bowel gas, or it could just be a poor quality film. So really, we should be moving towards low dose CTKUB, so where they're under 2 millisieverts, and that can be either for the whole KUB or a pelvis only scan, which is a much more reliable measure of whether the stone's gone.
Okay. And if the patient passes the stone at home, is there any benefit of like bringing it to the hospital for like tests? Or just
yeah, there is. So the patients love bringing their stones for obvious reasons. It's been awful, agonizing pain that's worse than childbirth, and then suddenly they've got the stone, and it's so small, but they're so proud of it. So we get presented with them on a regular basis, and it is helpful if the patient's got a uric acid stone, which you confirm on analysis, or if they've got cystine stones, which are rarer, but both of which can be treated medically. So it's important to know. Whether they've got calcium oxalate or calcium phosphate is of less relevance, probably, especially for a solitary stone. But yeah, it's a useful thing to do. So they should be encouraged to bring it along.
Yeah, and can you clarify the CT and X-ray difference? I know we discussed it before, but I believe it's like a little bit confusing in terms of like, because I believe in Poland we, as I said, mostly do the ultrasound. So yeah, but in the UK you always do CT, right? So,
yes,
and then X-ray as a follow-up more.
It used to be that we would do what was called an IVU, so an intravenous urogram, which was where the patient had intravenous contrast and then serial x-rays. And so as the junior doctor in urology, you would be taking x-rays every few hours to check whether the contrast was moving through and where the obstruction was. Then we move to a combination of ultrasound and KUB x-ray, because it gives you an estimate of what's going on. So you can see hydronephrosis, you can see a stone, and therefore you assume that they're related, but it doesn't give you information about the contralateral kidney, and it doesn't give you much other information. So we would use CTKUB and a baseline plain x-ray if the stone isn't visible on the scout film.
Okay. Yeah.
But it does depend what facilities you've got available, and if you haven't got CTKUB available 24/7, then ultrasound KUB is okay.
Okay. And I think that's all the questions. I can't see any more. If there will be more, I will just email you them later.
Okay, that's fine.
Yeah, thank you so much for finding the time to do this webinar to teach us.
That's a pleasure. Thank you for having me. I would love to hear the return in Polish, but with some translation device running alongside.
Yeah.
When you're all urologists. Lovely.
Yeah. And I just wanted to say that you always recommend urology as a specialty, saying that it's a really good mix of medicine and surgery. So we finished our urology month as a women in surgery group, but still I think this is a good closure to it, this webinar.
That's good.
This positive accent of urology is cool.
It's wonderful, and we need more women in urology. So if anyone is interested, come along.
We definitely do need more women. We just had a Q&A a few weeks ago, and we were discussing it as well, that there are not many women in urology, especially. So if they decide to do surgery, it's usually something else. Yeah, but I'm happy that you're encouraging women to do that.
Yes.
I feel encouraged after those 4 months.
That's very good, Kasia. We've got one signed up then. We'll take you as a sign up. Okay, thank you.
Thank you so much. And see you tomorrow.
Okay. Bye.